Could I ask the people who are on the phone to make sure you mute your microphones or from remote sites? Thanks so much. Okay, so we'll get started, and it is my pleasure to have Dr. Jake Onrot present to us, Hickam and Ockham and Bays, oh my. So Dr. Onrot's a clinical professor in the Division of General Internal Medicine. I would say he's a master clinician, and his area of expertise over the years has been in hypertension. He is a sage advisor to all the doctors who are providing care in hypertension now, and we are looking forward to hearing his talk. I just also want to mention that next week's presentation is by Physical Medicine and Rehabilitation, entitled Severe Stroke and Brain Injury from a Physiatry Perspective. Thanks.
Thank you. So when I was the chief resident about, I don't know, it's in another century anyway, we'd get up in front of the board, we'd get presented cases. Fantastic, thank you. This is one of the best sounds in the world. We'd get presented cases, and I'd sit up there and I'd ask, what do you think this is? And the person that would come up with the biggest number of differentials wins, right? That's how medicine used to be. We'd fill our brains with all the facts we possibly could, and we would be able to regurgitate them. If we really wanted to learn new facts, we had to go to the library. Then we had to go to Index Medicus. Then we had to go through the 10 volumes of Index Medicus to find the proper thing we wanted. Then we'd have to dig out the actual journal. Then we'd have to probably photocopy the paper. Then we'd get a few references from that paper. Then we, et cetera, et cetera, et cetera. We have this new thing now. It's called a computer. It does almost all this information storage for us. So what we need to do is we need to be better thinkers, because we have this memory device now that we never had before. So we need to learn to think, and we need to learn to retrieve. So this talk is about thinking through things and retrieving things, and just giving some tips. They're very simple cases, and it is audience participation. So you just yell out whatever you think, and there's no wrong answers. So I have no disclosures, and I just love this stuff. I was a blood pressure specialist for many years. When I retired from outpatient medicine, my interest became diagnostic reasoning, and I owe so much to the chief residents and to the master group that have been instrumental in publishing on this kind of thing. We're going to sort of try and figure out how to best look after our patients, the most elegant fashion, the most economic fashion, and the fashion that's best for the patient. And I'll show you how to do this and what we're doing with pre- and post-test probabilities, and I'll show you some of the traps, and then I'll share my experiences of all the traps I've fallen into, and had colleagues to send down the rope ladder to haul me out of them. And then we're going to talk about seeing the chessboard, which I'll explain. So who knows who this is? Criminal. Yeah, it's a criminal. It's a bank robber, I'll tell you that. It's Willie Sutton. And they said, Willie, why do you rob banks? And he says, that's where the money is. So it's one of our tenets in medicine, which is go where the money is. Okay, so this is a go where the money is case. This is a 48-year-old IDU male with back pain and fever. He'd had severe acute mid-back pain, fever and chills, weight loss, but no bowel or bladder symptoms. And he was tender, afebrile, but tender over the midline. Any ideas? Junior residents, senior residents? What is this? Sure. So this is so common, we see it so often, I call it Cassin's triad. IDU, back pain, fever is epidural abscess, osteomyelitis, spine, some infection in the spine till proven otherwise. Cassin's triad. Don't ever forget that. And so that's kind of our epidural abscess. And for every disease, we have an illness script. So our illness script for this kind of thing is A patient has a predisposing condition, the bacteria gain access and cause the infection, and then you see the pain and plus or minus neurological symptomatology and systemic symptoms. So this is, what would your pre-test probability be that this is an infection in the spine? Seniors, think back of all the cases you've seen with that presentation. How many have turned out to be an infection of the spine? Yeah. Almost all of them, right? So you'd be 90. Right now you'd be 90. So none of you do this. I'm the only guy in the world that does this with every case, but you think of your pretest probability, it's like 90%. Not the only guy in the world. So now we get some more information. Does it change your probabilities? There's the stuff that you have there, the CRP of 90 sort of confirms what. So now what's your diagnosis? What's your pretest probability? Has it changed? Are you sure? There's a reason everything up there is up there. So what's the kicker up there?
Well, there's more, looks like there's something more chronic going on. He's anemic, he's got thrombocytopenia, and
well,
white count isn't remarkable. So
no.
It doesn't look like an acute problem. He didn't have a fever clinically. I'm wondering if something a little more something.
Right, and I don't think you're highlighting the biggest abnormality that's up there. And that was the pitfall that you guys are going to fall into, because you're totally focused on this guy with his back infection, but what's the biggest abnormality up there? He's got an MCV of 65. Now, the first thing you'd think of would be, where are you from? Because you don't expect him to be that iron deficient. MCV, that's a very serious degree of iron deficiency. So my first question is, where is this guy from? Is he Thal? He's not Thal. So he's Caucasian with an MCV of 65. He's severely iron deficient. We see lots of IDUs downtown East Side. They're iron deficient. We don't see MCVs of 65 generally. So that, to me, tells me something else might be going on. Now, is it a Hickam, which is patient can have as many diagnoses as he damn well pleases? So he's got an infection and he's got an anemia. Or is his presentation, is there a way we can lump it with his anemia? And if there is, and we can come up with that, that will lower our pretest probabilities. But if not, not. So can you think of anything that links the MCV? Okay, let's turn off our brains and not make them an IDU. So if you saw someone with iron deficiency, anemia, and back pain, what would you think of? Cancer, metastatic cancer. Is there another disease you might think of? If you're a gastroenterologist? Inflammatory bowel disease. IBD with back pain, right? So this is sort of how the demographics, the illness script, how the patient actually presents, and also how you frame the case. So if you look at this as a low MCV guy, it's one, and you try and filter it in through everything else, it leaves you in a different track. But it's a very low probability track now. But any other probabilities that arise during your thinking process have to add up to 100% for all your pretest probability. You cannot break the immutable law of the universe. There's none of this, I gave 110%. Right? All your pretest, once you tell me your pretest probability for this is 60 and for this is 40 and for this is 50, it's fallacious and it's going to lead you down the garden path and you're going to make bad decisions. Okay? So this is what I want to talk about. There's two reasoning streams, and I'll just share a little anecdote. I was camping. I was on a cliff watching the Tesico River join the Chilcotin River. One of them was a muddy river, and the other one was glacier-fed and beautiful green. And the two of them would join, and you could see a mile downstream where you could actually still see the two rivers separate, and then you could sort of see them meld into one. And what we want to do is take our two reasoning streams and be like the BC rivers. So the first stream is what we all do, which is what we look for, the aha moment, or, Barry will come up with a diagnosis early on in a morning report, and it'll turn out to be the right diagnosis, and everybody will go like, well, how did he do that? Well, he did that because of experience, pattern recognition, heuristics, which I define as the farmer's insurance guy on the football commercials. We know a thing or two because we've seen a thing or two. And Gestalt, and gut feelings, right? And so that kind of stream will get you to the diagnosis, but you always have to put a pretest, a post-test, or a pretest probability. You always have to be working with probabilities. So it's not 100%. So as a wise philosopher once said, it ain't over till it's over. Who said that? Yogi Berra, of course. Lawrence Peter Berra, as we know him. He was a baseball player, and he always said these things that sounded really dumb, but were really smart. He was kind of a genius, but only a few people really recognize that. That's stream one. That's the Tesico. Then the Chilcotin stream is what we teach you in medical school, which is you do a systematic approach, you work with your problem lists, generate differentials. But we don't teach you enough about assigning probabilities. That's what you don't do. And that's what if you can strengthen your ability to diagnose if you assign probabilities. And based on those probabilities, you devise a test. And in advance, you start thinking about, well, if the test is this, I'm going to do this. If the test is this, I'm going to do this. And all your probabilities are revised after the test, and it determines what you're going to do. And it's what I call seeing the chessboard. And most people will sit there and order the MRI. But they haven't got and they've got a plan for if the MRI shows what they expect it to show, but they don't have a plan for anything else. So everything is reactionary. You're reacting to everything, right? So that's why we want you to at least use this other stream and see the chessboard. And then you keep doing this until you get your diagnosis. And again, it ain't over till it's over. It's tissue basically is about the only thing that's going to be 100%. Radiology is usually about 98%, but we'll show you can't always rely on radiology. And you've all seen this slide before, which is if you do use probabilities, then you stick the patient wherever you think they are on this from 0 to 100% for a specific diagnosis. You own that. Nobody else can tell you what to do, where your probabilities are. That's yours. Also, your thresholds. For instance, my threshold for possible meningitis is very low, and I'll do an LP in someone if I have a 5% pretest probability. But if I think someone has pimple, my threshold for proving it is much, much higher. So those kinds of things are also very independent and very experiential based on your own experience, but they're yours. You own them. So there's a threshold above which you're close enough to your diagnosis you're going to act, a threshold in between where you may act or you get more tests, and there's a threshold below which you're confident that that thing is ruled out for now. It can always be brought back, but it's ruled out for now. And that's how we work with our diagnostic processes. So what I like to do with my problem list, and this is from work from a guy named Cutler, who I was given a book. He's written a book on problem-based diagnostic reasoning. I was given it by Bill McDonald, who was an anesthetist here for many years after he was my senior and in that book, the guy talked about how you take a problem list and you group things and you resolve your problem list. So now, what do I know about resolution? Well, I know about TVs, right? Second allusion to TVs. I'm a child of the electronic age. So we want to, with our problem is we want to move from standard definition to HD to Ultra HD is what we're trying to do. So in this example, we're taking our abnormality and then we cluster it, and then we have a pathophysiologic state, make our diagnosis, prove it, you know, with a biopsy or with blood cultures, and then we have we've worked from back pain all the way down to staph epidural. And that takes a couple of days, whatever, but that's what you do with your problem list. That's how you work with your problem list. And I'll show you another case where the problem list is the answer. Okay, there's Yogi, catcher for the New York Yankees. I won't hold that against him, though. Okay, so we've got back pain, constitutional symptoms, background of infectious disease. He's a low MCV anemia, and his fifth problem would be dyspo, because dyspo always starts on admission. So what this illustrates is it's what you don't see that gets you, and things are not always as they appear. And this man had metastatic colon cancer. And the big clue that jumped out was the MCV. But how many people are going to write down the MCV? And seriously, you tell me a guy's in an IDU is 10, their hemoglobin's 102. I'm not even going to probably ask you what's the MCV. I should, but it's not it's not like hearing, you know, if someone else had it, because I'm used to seeing anemia of chronic disease or iron deficiency anemia in this population. It has nothing to do with their infection or something like that. Okay. So I actually got taken away by this case as well and blown away by the CT. And of course the patient was already on ceftriaxone of vancomycin. So we have to be aware of anchoring bias. This is a great case for anchoring bias. When you hit something that right off the bat fits your stream 1 and you're at 80, 90%, you just start looking for things to confirm it, and your differential isn't too wide, which is fine, but you have to be open, right? And premature closure, so it ain't over till it's over. And there's a number of cognitive errors that this kind of, somehow I got the background noise on this slide. I have no idea how. I couldn't get rid of it. So it was probably, I stole the slide off somebody's talk, and I had video on my phone by mistake rather than photo. Has anyone ever done that? Only me. Jeez. Okay. So this shows the anchoring bias, availability bias, because we see it all the time. Confirmation bias, we're just looking to, but we didn't have confirmation bias because it happened to make our diagnosis anyway. The momentum, framing, it's how you frame the case, right? Couple of other biases here. I should have said something funny, like 1950s sitcoms with the laugh track. You know, here's me Seinfeld up here. Okay, so this case is there's a million cases, and the cases are just like jigsaw puzzles, really, aren't they? The more information you have, the more pieces you have fit together, the easier it is to fit together the rest of the pieces. And then there's this beautiful moment where Dr. Casson comes up with this within 10 minutes that it's Osler-Weber-Rondeau or something like that, you know, and that's what I call the epiphany, and it's a high probability hypothesis that occurs to you out of the blue. But is it really out of the blue? Never, right? It's always based on your jigsaw, where you are with your jigsaw puzzle. You might get that one, you know how a jigsaw puzzle, you get that one piece that fits in that one place, and it locks the whole thing. And that's so they're not mutually exclusive. And I'll talk about the key log, which is really that one piece in the jigsaw. Okay, now we talk about framing. 5 different internists can look at the same patient and pull out 5 different groups or constellations of pieces of information and come up with 5 different diagnoses. Just like the blind men touching the elephant, and they think they think it's a rope because one guy's touching the tail, the other guy thinks it's a wall, the other guy thinks it's a bamboo shoot. You get the picture, right? So framing is very important. Sometimes it's really important to step back and reframe the case. So we use multiple lenses to reframe. If we talked about this, we could worry about the MCV later, or we consider that iron deficiency anemia in a male or a postmenopausal female is GI blood loss till proven otherwise, which is something that I had drilled into me as a medical student and has never let me down. And then you start trying to fit it together, and then you come up with cancer, right? Or if he had back pain, and it would be possibly Crohn's. It all depends on your illness bubble. We used to call it the Beery bubble, because when Beery Mangat was our chief resident, she would always draw a bubble on the board and stick in it IDU or, history of TB or whatever descriptors of the patient that we needed to know demographically. Okay. Any questions about that case? Very simple, very quick case, but illustrates all of these great points. Yes, Dr. Russell.
One of the questions I had, how often would you see a patient with IDU abscess with a normal white count and a normal temperature? Would that, it would happen occasionally.
Yeah.
But that struck me, that's why I said it looks like something more chronic. It doesn't look acute. The MCV, I quickly glanced at that and moved past it too quickly. But it's important also, I guess, what I'm trying to say, the MCV was a positive clue.
And the lack of
white count, the lack of temperature were negative findings that were
That's a good point. So most of the time, we do see patients and they've got systemic involvement. And but because we see so many of these patients, every CTU, like every day, every couple of days we see one at St. Paul's, there's going to be a large number of patients that will actually, maybe if it's 2% and we see a couple of hundred a year, where there's going to be there's going to be lots of patients that actually present like this, a lot more patients presenting like this than present with unusual illnesses. So, but you're quite right. It would have lowered your probability if they had, a white count of 26,000 and temp of 39.3. You'd be 99%, and you'd probably be right.
Right. Well, yeah. That's what I was
That's a good point.
Allude to is if you had an algorithm where you punched in numbers and it spit out a probability, and it put in normal white count, normal temperature, it probably would have lowered it by at least 20%.
I would agree. I would agree, and that's what your brain we all have our own brain algorithms that come up with our own pretest probabilities. It might have lowered you by 20%, might have lowered me by 10, might have lowered someone else by 50, and that's experiential based, and that's a very good point. Next case, another simple case, okay? Very simple. 27-year-old female, former IDU, swears that she's been clean, comes in with right upper quadrant pain for a day. She had a cough with some sputum and then presents with this right upper quadrant pain going to the back, which is a little bit pleuritic in nature, but no bowel symptoms or anything like that. And on exam, she was tender in the right upper quadrant. She was febrile, and she had a negative Murphy sign. So at this stage, would you be thinking of any possible diagnoses? Right upper quadrant pain and fever in a 27-year-old female?
Maybe biliary tract.
Biliary. So biliary is the first thing that comes to my mind. Any other possibilities? Pneumonia. Something abutting the diaphragm. Okay. Those are good possibilities. A subphrenic or a hepatic abscess. Some infection in the right upper quadrant, not biliary associated. Very good. Any other things cross your mind? Empyema, so complication of a pneumonia. Anything else? Okay, that's fair. And your blood work, again, there's nothing pointing to infection really. And minimal elevations in the transaminases, which can be attributable maybe to chronic hep C. She's not pregnant. A D-dimer's done. It's 1,000. And she gets an abdominal ultrasound, rightly so, because we're thinking biliary and it's negative. Now, let's take those probabilities. A negative ultrasound, is this biliary tract disease?
What's her body habit?
She is moderately obese, not really, not to the degree that it'll inhibit your ability to make a diagnosis based on her body fat. So what's your probability it's biliary now? Depends where you started, right? The negative ultrasound is going to lower your, it's a test. Now you've got a post-test probability. So wouldn't it be nice if you knew the likelihood ratios of a negative ultrasound? And wouldn't it be nice if you had a pre-test probability and you knew how the test performed and you could actually get a post-test probability? And I haven't told you the chest x-ray, right? Okay, but just based on this, Jim, how high were you that this was biliary tract?
I was
at first.
A bit higher than respiratory, but pleuritic pain, you'd have to think respiratory system. So I had biliary number 1 and a pleuritic process.
And I too. And when I was presented this case in the morning, and we used to present them in the cafeteria because we had morning report in the cafeteria, I leaned across the table and I said, I think this is gallbladder. I'd say about 75, 80% gallbladder was where I was. Then they told me there was a negative ultrasound. I said, well, that's a pretty high pretest probability. I still think it's gallbladder. How does an ultrasound work in this situation? It turns out it's in the 90 range. So I was able to downgrade my probability from 80 down a bit. Then I was told the chest x-ray, and if I was told there was a right lower lobe pneumonia, it would go way down and pneumonia would go way up, but the chest x-ray was clear. So those of you who were thinking pneumonia and pyema, depends where you were. If you were 20% and you had a negative chest x-ray, your post-test probability would probably be low enough to forget about it. But if you started at 70% for pneumonia and you got a negative chest x-ray, you'd be at 40% or something like that, not enough to forget about it, and you'd do another test. Remember that 0 to 100% thing. Okay, so what test would you do now?
I'd like to look at the liver. First of all.
You've got an abdominal ultrasound, so how better can you look at the liver? CT abdo maybe.
Yeah.
Okay. Anybody want to do any other tests? All right.
CTPE protocol?
CTPE protocol. What's your pretest probability after you know the chest x-ray negative and the ultrasound's negative?
It's increasing from the start.
And what was it at the start? Nobody even mentioned it.
I shouldn't.
Yeah, but it would have been low at the start, right? Reasonably low. Until you knew the that's how PEs work, right? Diagnosing PEs work that way because they start building in probability when you've eliminated the other stuff that's pretty obvious. So I agree with you.
So you also want to use bulk criteria.
Right, and she had none.
Jen and I also said CTPE. And our probability is low, but everything else drops. This starts to go up.
Exactly, we have
Even
to add
if
up
it's
to
low,
100%. Great point.
And even if it's low, you don't want to miss a PE.
Yep. So what was done was a CTPE protocol and an abdo. And you'll see later, I always say, if you're going to do a chest, always think about whether or not you should do an abdo with it. And that was the appropriate, both of them were done. PE. So, what was your pretest probability before you did the CTPE protocol for PE? Keith, did you?
It's about 50%.
You were about 50 to start.
A lot of the other stuff is being figured very quickly.
So this is a perfect example of how using the probability stream determines what you do. So if you're 50%, you get this. That puts you at 80, 90% because it's a very high likelihood ratio when they tell you it's a PE. Okay, so you're going to anticoagulate, right? Cam, if you started at 30 or 40, you'd anticoagulate, and the patient was anticoagulated. Okay, I, on the other hand, had such a low pretest probability at the beginning. I didn't even think of it, right? So then I would automatically say, when someone mentions it, I'd say, okay, well, I'll give you 5%. This is a positive test. I have to know how often there's false positives, etc. And I will caution you, this was in the early days of CTPE, when we didn't know about subsegmentals and we were overcalling them anyway, and there was that kind of background. So I started at 5. The ultrasound and the chest X-ray were negative. I might have been at 20 max, and I get a positive test. Now I've got a positive test. I still have a low pretest probability.
The interesting thing is why was the D-dimer done?
Exactly.
Somebody had some higher pretest probability. Usually somebody comes with way up a quadrant pain, you're not going to order a D-dimer.
Correct.
Someone was thinking that.
No, it's our emergency department.
I'd like to believe, yeah, so I'd like to believe that everybody practices medicine that way, but of course it's just part of their routine. So this is the thing. We see all these tropes that are done in patients that don't have anything to do with the heart. We see these D-dimers that are all done. We have to know how to deal with them, and this is how you deal with them, right? So I was in the realm of 30, 40% after this. I still had my doubts, but maybe 50%. But I was kind of ready to anticoagulate, but I wanted to get another test, right? Which there really isn't a better test than the CTPE other than the pulmonary angiogram, which we never do anymore because the CTPE is so good. What do you do now? This part's simple. If you have any doubts about a radiological report, okay. So the next morning, on my way up to radiology, we actually just checked the computer and it was a corrected report. This had been the resident in the middle of the night. They'd overcalled, and it was reported as no PE. And it just shows you this is an example of Bayesian reasoning, where if you have your probabilities, and depending on what you did, Keith, with your 30% that went up to higher was completely right. What I don't like is when someone has a 0 to 5% probability and they get a positive test and then they blindly act on that positive test without, because that positive test puts that person still in the low range where you need more testing, kind of thing. So it turns out, and I hadn't really thought of this either, because I was anchoring on the right upper quadrant, right? Because I wanted to do a CT. Yeah, this is biliary, right upper quadrant, pain and tenderness. And this was one of those rare cases where Pylo presented with right upper quadrant pain, tenderness, and pleuritic pain. And now we know, we didn't know before, but now we know radiologically they can find Pylos on CT scan because of the stranding. The Pylo doesn't just hurt your kidney, but it causes a reaction around the kidney, which may have been this thing. So anyway, this is an example of Bayes' theorem. Just as long, and there's no problem with anticoagulating, just as long as you don't blindly go based on that result, you want to get more information till when the dust clears. I had a patient that was slam dunk PE that I really didn't want anticoagulant, had previous PEs, etc. And it took me going back 10 years of VQ scans and CTPs to find out that it was a chronic thing. So this happens.
Can you go back to the lab work just for a sec? There. Pretty remarkable.
Pretty remarkable the other way for someone to have acute pyelonephritis this bad in an somewhat immunocompromised host, again, and have a normal white count. So I guess one of the things I'm learning from what you're saying is for routine cases with common presentations, then you're probably not going to be as needy of this reasoning, because most of the time you're going to be right. But when you have two cases with slightly unusual presentations, that's where you're going to really miss it if you don't think laterally or use some pretest probability logic. Is that a fair comment?
That's a fair comment, and in fact, what the hell am I doing here if any MSI can come in and make a diagnosis and look after my patient, and I might as well sleep in and go to the ski hill, right? So this is something that comes with experience, and it's not, in my belief in medical education, it's not formalized enough or taught enough. I just want to make you guys think about this so you engage in these parallel streams. And there's literature now that the two streams, the heuristic stream and the reasoning stream, they activate different parts of your brain, like the Chilcotin and the Tasico. So they are actually synergistic when you use them together. And I mean, that's PET scanning. I don't know if the science is that great, but it fits my worldview, so I'll quote it. So Bayes' theorem says the probability of an event depends on the prior probability. And I'll show you a good example of this. This Coke is really jazzing me up here. I better go faster, though. Okay. So if you go to the literature, we know that there's about a 1% false positivity of the screening HIV test, which is why we always do the confirmatory test. We used to get the screening test and then wait a day or two for the confirmatory test. Now pretty much it's all a moot thing. But here's an example of how the math of Bayes' theorem works. So if you, in 1990, if you were an IDU admitted to St. Paul's Hospital through Emerge with an infective complication, you had a 35% chance of also being HIV positive. That was the prevalence in the downtown east side injection drug use population. Thanks to Julio and his gang, it's nowhere near that anymore. So in BC doctors, I just made up this number for illustration purposes, in 1990, maybe let's just say 1 in 1,000. And if you're a medical student, substitute medical students for that. Make it real. So if you have 10,000 IDUs, you get 3,500 true positives, 100 false positives. So your chance of a positive being a true positive is over 99%. So you can act on that assumption that that person is HIV positive. If that person was a doctor with no HIV risk factors, 10 of those would be true positives, 1 in 1,000. But 100 would be false positives. Your chance of a true positive would only be 9%. So you don't go and tell your colleague that you've just admitted through Emerge with Pilo that they've got HIV because of this test. It's 10 times more likely to be a false positive. And that's how Bayes' theorem works, which is those are your pretest probabilities, right? So you generate your pretest probabilities. If you know how a test works, you do the math. And then you don't have to do the math because you can go to the literature, find out how these tests work, and use your pretest probabilities and draw a line right between pretest and likelihood ratio to get post-test. Okay? And remember that you're out, and wherever it puts you on this, and you own this where you put the probabilities and the lines. And remember that medicine's not binary. It's not yes or no. It's probabilistic. Is that a word? Good. An example of that would be a ferritin. It's every ferritin below 50 is not iron deficiency. A ferritin of 20 and a ferritin of 40 are both below 50, but they have different probabilities for turning out to be iron deficiency. And I said in 1990 when this paper came out, every lab will have every test with likelihood ratios, and they'll present the results, and they'll ask you to plug in your pretest probability, and they'll give you a post-test probability. And I predicted that was going to happen in 5 years. I predicted it 25 years ago. So I'm glad I didn't bet money on it. But wouldn't it be nice? It should. And like troponins, we would have saved millions of dollars if there was a graph like this in Emerge for troponins, and we would know, we'd have a 0 pretest probability for a trope, but it would be drawn as part of a routine thing, and you'd have a trope of 30, and you would know how many tropes of 30 turn out to be MIs. And you'd look and you go, I don't care. It's not going to be an MI, and you move on. And you don't do serial tropes, and you don't get CCU consults. You wouldn't believe the number of CCU consults when tropes came out. It was amazing. I wish somebody would figure out a test like that for internal medicine, and we could just stamp it and go, demand ischemia, not a candidate for CCU. Okay, so I'm going pretty slow because I'm talking a lot, but that's the Coke. Coca-Cola, I mean. This case is a tummy ache. So this is a 31 male who has sex with other males who comes in with abdo pain, and it's severe abdo pain. He's known HIV negative. He's been in Mexico a month ago, and he has a family history of Crohn's. He comes in with a day of diarrhea, nausea, and vomiting that kind of settles, and then he gets pain, which is more right lower quadrant, but when you see him, he says it's fairly diffuse. And his temp is 38. Anybody thinking what this might be? This side of the room. Any possibilities? What's the first thing that springs to mind? The quiet side of the room. So it could be a Crohn's flare of some sort, because he's got the family history. Pretty cute, but could be. Okay. Any other demographic in the bubble? Anything up there in the bubble that makes you think of any particular diseases?
He's just been in Mexico for a month.
No, he was in Mexico, came back a month ago. And that's an important point, because if you go to Mexico and get sick from a GI illness in Mexico, you don't, it's going to be within 2 weeks usually, maybe 3 weeks. It's probably not going to be a month, but it still has to be considered because amoebas and stuff can be a month out. Any others?
Infection is number one. It's just a day, cramping, not vomiting and diarrhea. I think infection is highest on my list.
Okay.
So gastro.
Gastro, yeah, okay. Now, you examine the patient, believe it or not, and they look really sick. They're tachycardic. They're very tender. And they have guarding, and they have rebound. They don't have McBurney's point tenderness or anything like that. And we always do a rectal and abdo pains, because if you don't put your finger in it, you'll put your foot in it. And the white count's 22,000. So this guy is telling you he's sick. Now, what is your provisional diagnosis based on all of that? Anybody?
Acute peritonitis from something.
So he's got an acute abdomen.
It would be enteritis.
Yeah.
But he's got
It sounds like an acute abdomen, right? And that's the one thing you can't miss. So your line for investigating and suspecting it, that doing more testing, everything shifts like a meningitis, because it's really serious. You can't miss it. But there is a differential of infection because of MSM and Mexico. There is a differential of Crohn's, right? Be very careful the information you give the radiologist. Sometimes you can give them too much information. TMI. I should call this the TMI case. So this is our differential. Where would you put acute abdomen?
Number 1.
How high?
I put it with the
Percent.
down, I put it 80.
Good. 80 plus, right? And you can't miss it. So even if you have negative, Bayes says, even if you have negative tests, unless those tests are like these incredible 100, 200 negative likelihood ratios, you're still going to be high no matter what you do, and you're going to need a surgeon, and you may even have to do a diagnostic laparotomy even if you can't prove it because you're so high, right? That's the key to the stream number 2, okay? So CT's done. There's some thickening in the right around the ileum. The radiologist queries Crohn's. Surgeons are called, of course. I don't think that the staff surgeon ever saw the patient. It would have been the middle of the night. The resident would have gone in and phoned the staff, and the staff would have heard that the CT was a possible Crohn's. Gets referred to me. What are your thoughts? As the internist at 7 a.m. coming in to see the patient. Well, some of you know me. What do you think my thoughts were? I am furious because I put my hand on his belly and it's an acute abdomen, and surgery has said refer to medicine. I'm furious, and it's Bayesian. So I was stream 1. Like, I didn't care. I was just, I've seen it. It's acute appendicitis or it's a perf or something. So the next thing I do is I go and find the staff radiologist, and it was acute appendicitis. So you cannot always believe your negative test when you have a high pretest probability. So if you do the math, and then 93%, there's a 5% false negative rate for CTs diagnosing appendicitis anyway, so that if you had that high pretest probability and you were a good surgeon and you got a negative CT, you may want to take a peek anyway. Jim?
Back to the vital signs slide. This is like you and me back being med students in Toronto. You and me being med students in Toronto over this. I think the thing that's jumped out to me, it's pretty unusual for someone to have a heart rate of 120 at that age, and a respiratory rate of 18, a temp of 38, and a white count of 22,000. I suspect there was a left shift. With
Yes.
those abdominal findings, that would be probably more, to me, over 90% acute abdomen.
Yes.
It would be pretty, I mean, it would be really
Right.
rare for someone to be that acutely ill. And the second point I would make is there's new definition now for sepsis, septic shock.
Yes.
This is a high-risk guy who, he's the kind of guy we sometimes in the ICU get called at 2 in the morning because he's now hypoxemic or obtunded or hypotensive. So if he does get admitted to the ward, this is someone that the residents and students have to keep a close eye on, and maybe even consider putting him in, if we ever open a step-down unit, in
Yes.
an immediate care unit, because he's really quite sick. I think that's the main point.
Yeah, to your second point, he's really sick, and for sure. To your first point, it is, if you're a junior house staff and you have no experience, and someone tells you it might be Crohn's disease and they don't say anything about appendicitis, what are you going to do? But if you're a junior house staff and you've done your pre-test probabilities and you've gone to this lecture and you know what your post-test probabilities are still high, and you know that Bayes' theorem says a high probability pre-test, a high pre-test probability with a negative test, you have to think it's a false negative. You won't fall into that trap, and that's why I'm presenting this case. And you don't need, I just made this point. You don't need to be an expert to be an expert. And in the old days, we didn't have CTs. You know, you had to accept that you were going to operate on some people that didn't have appendicitis. Otherwise, you'd be missing too many appendicitis. And they actually did a study. They came up with a magic number of 93% for surgeons. If they're operating on 80%, if they're only finding appendicitis in 80%, they're operating too much. If they're finding it in 100%, they're not operating enough. You have to accept 7% error. It's almost like it's not about being right, it's doing the right thing. And the right thing is to operate, and you're going to be wrong 7% of the time. So this is, and P.S., for Dr. Russell, it had already perforated. But he did well. He did very well. This case, oh, geez. I'm going to skip this case. This was a case of postprandial vomiting. What do you think of when you see postprandial vomiting? Gastric outlet obstruction. I thought this guy had a gastric ulcer or a gastric malignancy. but he had CNS findings, and they thought he might have had asterixis. So if you just took it as it is, it would be I'd send him for a scope. But asterixis has a very short differential diagnosis, and so we did a creatinine, and we looked at his liver, and you would also look at his bicarb to see if it was a CO2 retainer, because those would be the main three. And his creatinine was 1,300. And it was, I don't know why it was postprandial or whatever, but this is all about Mickey Mouse stuff, about working with a problem list. And Ockham and Hickam, as you guys probably know. I like Einstein, keep things as simple as possible, but don't oversimplify. But the KISS rule is usually pretty good. And that's how, and by trying to put the patient, put them all together, and the asterixis has a short differential diagnosis, what I call the key log, or the piece of the jigsaw puzzle that opens it up. And you guys have heard me talk about that. You always look for a key log to try and unlock a puzzle. And the asterixis was that. You can also drift net, like Paul Watson, who got arrested for protesting drift netting. And then when you drift net, you just have like 3 things, and each of them's got 15 differential diagnoses. And what is common to all 3 things? Who does that? Google. That's what Google does. So that would have given you renal failure would have come up under asterixis, under confusion, and under vomiting. So that's how you do it. That's how Google does it. And Google has made my most incredible, many of you have heard about my incredible case that we had that was diagnosis by Google. So your Google finger is smarter than your brain. And I just want to do this last case because this was kind of embarrassing. It was a CTU case. It was a Mandarin-speaking male, no English, and there was a language barrier, and it got in the way. But he comes in with fever and chills for 4 days, dry cough, temp 38.3, sent home from Emerge. He has slight elevations, if you notice, in his ALT and AST, and he's hyponatremic. And he's sent home from Emerge. I think nowadays we'd probably, if we were going to send this guy home, we'd make sure he didn't have what diagnosis? Fever, chills, dry cough, St. Paul's, January, influenza A, or a respiratory, or an atypical. You'd probably give this guy some Tamiflu, Azithro, send him home and tell him to fill the prescription depending on what the results of the NP swab showed. And we used to have to wait a long time for NP swabs, by the way. And his chest x-ray is fairly benign. You might question that there might be a little something starting up behind the heart there, but you don't really see much. But in retrospect, I don't see a nice sharp posterior border to the heart. But that's totally in retrospect. So he comes back 2 days later. They didn't give him anything, by the way. And he comes back because he faints, or he's almost fainting. Now he's really febrile, and they give him ceftriaxone, Vanco. His exam's unchanged. Look at his transaminases. Okay? And look at his iron saturation. Okay, but you're in Emerge, you're admitting him. You sort of park those things, right? Because now he's developing a bit of a right lower lobe pneumonia. So you treat him for pneumonia, and you park those things. And that's not bad. You go after them. But in this guy, they treated him for pneumonia, and they forgot those things. No bueno. So this is what happened. They gave him ceftriaxone, azithromycin, and he grew Pseudomonas on sputum, and he was not getting any better. Now what? He's changed to Peptazo. Why? Because he grew Pseudomonas on sputum. Are you guys still cool with that? Well, you would be if you forgot about the AST, ALT, and iron deficiency. So he's no better. Now, if you did a problem list, and that's all it had on it, you diagnose them as non-resolving pneumonia and maybe pseudomonal, and what would you do? What would be your next test? With that problem list. CT scan of the chest, right? So remember, you got to reframe these cases. You got to take a look. Like this pneumonia's not getting better, and we always talk about wrong bug, wrong drug. We got the wrong source. We haven't got source control, or it's something else, right? And we go through this all the time. I went through it with my lady who passed away last night when her pneumonia just continued to worsen, and she was on every antibiotic known to man. We had to consider something else as a cause for her pneumonia. So if that's her problem list, that's different than if that's her problem list. So would someone like to suggest a possible diagnosis? He is febrile. He does have an infection. Where is it? Yeah. So they did a CT chest, but if they were thinking, and even if they forgot about this, but they didn't really they had to be looking for another source, you would have ordered a CT chest abdo-pelvis because the rule is, right? And so big time liver abscesses. And unfortunately, source control was not possible because he never agreed to getting them. But it wasn't, the Pseudomonas was a, we see Pseudomonas in sputum. It led you astray. And if you were anchored to pneumonia, you were anchored to pneumonia. But you should never have started being anchored to pneumonia if you'd done a proper problem list and looked at this case through a bunch of different lenses. Then this is what you don't want to happen, right? You don't want to see a CT on day 5 of a diagnosis that you could have made at the bedside kind of thing. And it happens all the time. It happens to all of us. But it'll happen less if you're a Chilcotin-Taseco River kind of guy or gal. And then finally, I guess we're just at the end. I always talk about seeing the chessboard. So a good clinician has a plan for the results of the test. Not that if it's not going to be what they think it is, they know what they're going to do next. And a master clinician has a plan for 2 steps. An Oslerian master clinician might have 3 steps. But they're sitting there in a merge, and they can already see day 3 and what's going to happen. And you don't have the dull moments and the surprises, but you plan for everything, right? And that's how your patients get out of hospital quicker, because you're not finding something out the next day when you were ready to find it out the day before, okay? So this is a very good way to move patients through the system, avoid extra testing, and be the best doctor you can be. So this is what I've always taught. And then I read this in a commentary about foreign policy in Iran and all this stuff, and this is a kind of it was a military guy likening army decision making with your armies to the chess, and you make a move and then whoa, so then you make another move, whoa, you make another move. By the time you've made 5 moves, you're so out to lunch, you're ready for catastrophe, right? So you have to diagnose and treat patients like a chess game. This is actually more important for treatment. You give them the Peptazo. You're ready. What am I going to do if they don't respond in 2 days? You've got a plan. So there's no surprises. He had metastatic adeno, and his liver was, we think, full of cancer and abscess. So that's my aside. If you're doing a chest, do an abdo maybe. Just ask yourself if you might want to do an abdo at the same time, and vice versa. So what happened? Well, they made the diagnosis because they did a CT chest because they were worried about non-resolving pneumonia. So it's better to do the right thing for the wrong reasons in this case than to do the wrong thing for any reason at all. And it's more important to do the right thing than to be right. Remember that we're going to be wrong. Medicine's not binary. You're never going to be right 100% of the time. You have to play the odds. That's why we do NNTs and relative and absolute risk reductions and likelihood ratios. We are going to be wrong. It's part of medicine. It's a probability. And you got to be good to be lucky. So these people were at least good enough to sit back and go, this patient's not getting better, I better do something. They got lucky. And the better you are, the luckier you get. That's a sports kind of thing. So they anchored on pneumonia, which is what I call a comfort zone diagnosis. I once diagnosed a stroke in a patient that didn't have a stroke, and the neurologist said to me, Jake, that's the last refuge of the diagnostically bereft. So I've always quoted that. That was Joseph Murata did that. And also, if your pretest probabilities are out of whack, your Bayesian analysis can fail. So that's when you really are going to need help from other people. And that's what happened here, because your pretest probability was so high for pneumonia, and it shouldn't have been because of the liver enzymes. Just like in the first case, it was so high for IDU abscess, but it wasn't quite as high because he didn't have the white count and he had that MCV. And that's, that's how you can know in advance. Okay, and that's pretty much all I want to talk about. The next case was a total mea culpa where I screwed up completely because I didn't. I did as I do, not as I say, sort of thing. So better we don't hear about that case. That's fine. There were questions all along. I'll stand here for 5 minutes if anybody wants to hassle me. You always come. Yeah, why not? No.
That was fun.
Yeah, simple case. No, it's simple. No, it's good. You were right on. It's simple. If we had started doing that and been taught that, we would have been much better doctors.
No.
We wouldn't have sucked quite as badly.
Some of the images in literature from McMaster when they started talking about...
Yeah, the PIAPED study.
Good. Like learning to take
finish up medicine or...
The PIAPED study was the first study that gave you the results of a test in the context of your pretest probabilities and told you what to do based on that. They just made you go low, medium, high. Oh, he was next. Thank you.
Yeah, thank you. My question was, when you have like a situation where this person's CT abdo is uninformative and undifferentiated abdominal pain, would you naturally want to lean on doing kind of what seems like a redundant test, like an ultrasound? Like you can look.
Yeah.
Because I'd be
so
like,
if you have a high enough pretest probability for something and it doesn't show on the scan,
right.
then you do something else. That puts you, and it's exactly what you do. So we do that all the time.
Well, that's
right?
and
then if it's another test, then maybe we let go.
Right.
So,
because you kind of like your post-test probability will become your pre-test for the next one. But we don't really like understand a likelihood ratio. If you have a normal CT abdomen, and then it's like you give them an ultrasound to see if you can find.
I'll tell you a case in a second. But it's exactly that.
Who's Hickam?
Huh?
I didn't know that.
Oh, Hickam was I didn't have time. I skipped through. He was a professor of medicine in Indiana and Duke, I think, in the middle of the 20th century. And he said a patient can have as many diagnoses as he damn well pleases. And everybody was like, we're all slaves to Ockham. But Hickam was able to show that as we get better at treating chronic diseases and patients live longer, they accumulate all these different things. So when someone presented in 1400 with fever, chest pain and whatever, you knew it was an infection. But in 1970, it could have been anything else. So that was Hickham's dictum. And I didn't hear about it till like.
I've never that airport basin on Oahu. There's an airport base.
There's Hickam Air Force Base.
Yeah.
It may be a relative.
Your Hawaii experience.
It may be a relative. I've always wondered about that too. Hickam Air Force Base. That's funny. So in answer to your question, I had a patient who was referred to me. We just wrote it up. Do you know Jessica Nathan? She's a R4 in internal medicine. Okay, she's around here somewhere. We referred Jessica. Do you know Paxton Bach, who does the addiction? He's an internist. Does addiction?
No.
Okay. So he was my junior attending. She was my junior maybe. And the patient was referred. The patient had a history of temporal arteritis. He'd been on prednisone off and on for 10 years. Had abdominal pain. Wouldn't go away. They gave her steroids. Wouldn't go away. They treated her for diverticulitis. Gave her antibiotics. Wouldn't go away. CT scan, unremarkable. Transferred to St. Paul's. I don't know what the hell this is. And so because she had vasculitis, this case illustrates a bunch of things too. Because she had a history of vasculitis, which she may or may not ever had, because she never had a proven temporal artery biopsy, but because I wondered if it was vascular, so she'd never had a proper CT angio because they were worried about her creatinine of 140 or something like that from hypertension. So we did a CT angio, and she had clot everywhere. And her abdominal pain was ischemic.
I see. Was she
So
having
we didn't-
like blood per rectum or anything like? Oh, okay.
So we did not. She had nothing, and it didn't show any colitis on nothing on CT abdo. So that was exactly the situation where we had a high pretest probability that something was going on in her belly because she was complaining of belly pain forever. And we knew it wasn't steroid responsive, although that should have turned me off vasculitis, but whatever. And we knew it wasn't antibiotic responsive. We knew we had to go do something else in the belly. And we did the right thing for the wrong reason.
Right, okay.
I wasn't thinking clot, I was thinking vasculitis, but she had clot everywhere. So that was a perfect example of doing another test.
Right.
And then there's a kicker. So this woman's been sick for 6 months, and her hemoglobin was 153. And Paxton went, why the hell has she got a hemoglobin of 153? Is she dry? And we go, no, she's been on an IV for like a week. She's not dry. Why does she have a high MCV, a high hemoglobin? And her then we looked, and her platelets were like 600,000. We're going like, okay, well, she's been infected. She's been sick for so long, of course her platelets are up. And then her white count was like 18,000 and wouldn't change with anything. And we go, well, and then all of a sudden Paxton went, no, we got to make sure she doesn't have polycythemia.
Okay.
And she turned out to have polycythemia. And it all, you know, nobody's, and within a day, 2 days of admission, we had her with polycythemia as her hypercoagulable state, on hydroxyurea, on anticoagulant, vascular consult, wrapped up. And it was only because we did the CT angio, which led one thing to the other. So it's exactly the case that proves your point.
Thank you.
And you don't have to be an expert to be an expert. What level are you?
I'm MSI 3.
Yeah. So you can function at expert level if you do this. Okay, see you later.
Thank you.
Very good thing.
Yeah.
You know,
It's so simple, eh?
It's not something. It's not very intuitive. We're all halfway what thinking. But great cases to illustrate those.
Every day. Every day. Close call illustrates some of these points. It's crazy how often.
We ignore it too much, though. It was actually an RCT specifically addressed that point about not being caught enough. Yeah, she did an RCT on medical student. The entire time they split hand. One class got Bayesian teaching, one did not, and they gave them cases. The Bayesian beat the other.
Of course, they always will, because And I always say to my students, this just is an add. It doesn't take away from anything else you're doing. It just adds. If you want to be better, do it. If you don't care, don't do it, right? But I cannot change the culture. I've been trying for 10 years. And all of these junior staff members now, you know, from voyeur up, from voyeur down, they've all sat in morning report and had me beat the shit out of them about days and everything like that, and it just has not pervaded because the culture's still
just thinking about pipeline track.
yeah, and all this stuff that they're making them memorize for their own college and all this stuff. And what I'm trying to do is change the culture.
Go ahead. Take care.
I did. Yeah. No, I didn't write a note because I did grand rounds. I didn't have time to write notes. I went around and saw all my patients because I knew I'd get busy, right? Yeah.
I stopped driving yesterday because I thought she was getting that volume overloaded, and I'm just wondering if you think that she should come under us and we should make her DNR1, or do you think there's further roles for you guys might go there?
Well, you know my thoughts, right? I think that she is terminal. I don't think she's responded to antibiotics. I believe that all care should be withdrawn and she should go to DNR1, but I was unable to get buy-in from Wayne.